Good afternoon, everyone. I'm Hahn from Samsung Medical Center, Seoul, Korea. These are my disclosures. These figures summarize recommendation for antithrombotic therapy in non-ST elevation ACS patients without atrial fibrillation undergoing PCI in 2020 ESC guidelines. The most prominent feature is a stratification of patients according to bleeding risk. In this guideline, the patients with a very high bleeding risk is defined as recent bleeding in the past month or not deferrable planned surgery. High bleeding risk is defined as an increased risk of spontaneous bleeding during DAPT, such as precise DAPT score of 25 or higher or ARC HBR. In East Asia, the proportion of patients with high bleeding risk was reported 27% to 35%, about a quarter to one-third in previous trials. Most patients have low bleeding risk. Therefore, let's start with patients with low bleeding risk. In patients with low bleeding risk, the guideline recommends 12 months or longer DAPT. One of the important issues in the acute stage is selection of a P2Y12 inhibitor and loading. In ISA-REACT 5 trial, the researchers compared ticagrelor versus prasugrel. In this study, both P2Y12 inhibitors were loaded immediately after randomization among patients with STEMI, while among patients with unstable angina non-STEMI, ticagrelor was loaded immediately after randomization, but prasugrel was loaded after the diagnostic angiography only when patients were scheduled to undergo PCI. Therefore, this trial compared ticagrelor versus prasugrel as well as loading strategy upstream versus at the cath lab. The primary endpoint was defined as a composite of death, MI, or stroke. At 1 year, the rate of primary endpoint was significantly lower with prasugrel than with ticagrelor, 6.9% versus 9.3%, and NT was 42. This difference is mainly driven by decrease in myocardial infarction in the prasugrel group compared with the ticagrelor group. Stent thrombosis occurred less frequently in the prasugrel group than in the ticagrelor group. Meanwhile, the risk of bleeding was not significantly different between the two groups. In subgroup analysis, the treatment effect of ticagrelor compared with treatment effect of prasugrel compared with ticagrelor was consistent, including clinical presentation, STEMI, non-STEMI ACS. Based on these results, 2020 ESC guideline recommend that prasugrel should be considered in preference to ticagrelor for non-ST elevation ACS patients who proceed to PCI. They recommend that, they stated that it is not recommended to administer routine pre-treatment with the P2Y12 receptor inhibitor in patients in whom coronary anatomy is not known, and then early invasive management is planned. So we can load P2Y12 inhibitor at the cath lab after diagnostic angiography. So far, the guideline for STEMI was not revised. However, the editorial from NEJM recommended prasugrel to ticagrelor in patients with the STEMI too. The other important issue is the duration of DAPT. Our group conducted a SMART Day trial. There is a prospective, multi-center, randomized, and open-label trial. 2,700 patients with ACS undergoing PCI using current generation DS were randomly assigned either to 6 months DAPT group or 12 months or longer DAPT group. The primary endpoint was an 8-month MACCE, defined as a composite of all-cause mortality, MI, or CVA. At 12 months, the rate of a primary endpoint was 4.7% in the 6 months DAPT group and 4.2% in the 12 months or longer group, which met predefined non-inferiority of a 6 months DAPT group. However, the rate of MACCE tended to be higher in the 6 months DAPT group compared with the 12 months or longer DAPT group at 6 months landmark analysis when treatment actually differed between each group. Especially, the risk of myocardial infarction increased with 6 months DAPT than with the 12 months or longer DAPT group. Therefore, the guideline recommend DAPT of aspirin plus P2Y12 receptor inhibitor for 12 months or longer unless there are contraindications or an excessive risk of bleeding. However, they suggest several options. Strategies to reduce the risk of bleeding after PCI can be classified into 3. Shortening of DAPT, de-escalation, and aspirin withdrawal. Today, I would like to focus on 3 recent Korean trials. The first trial is host-reduced polytic ACS. In this trial, the researchers compared reduced dose of prasugrel versus conventional dose of prasugrel after 1 month DAPT. The primary endpoint was net adverse clinical events, a composite of all-cause death, non-fatal MI, stent thrombosis, repeat revascularization, stroke, and BARC type 2 or higher bleeding at 1 year. The rate of primary endpoint was significantly lower with the de-escalation group compared with the conventional group, 7.2% versus 10.1%, which met predefined non-inferiority margin. Moreover, the ischemic composite endpoint was not significantly different between the 2 groups. As expected, the risk of bleeding was significantly lower with reduced dose than with the conventional dose, mainly decrease in BARC2 bleeding. The second study was TALOS.AMI trial that compared, that evaluated switch to clopidogrel. In this trial, patients with AMI undergoing successful PCI received aspirin plus ticagrelor for 1 month. After 1 month, the patient were randomly assigned either to aspirin plus clopidogrel group or aspirin plus ticagrelor group. The primary endpoint was a composite of cardiovascular death, MI, stroke, and BARC bleeding, type 2, 3, or 5. At 1 year, the rate of primary endpoint was significantly lower in the de-escalation group than in the active control group, which met a predefined non-inferiority as well as demonstrated superiority. Ischemic composite endpoint was not significantly different between the 2 groups, and as expected, the risk of bleeding was significantly lower with the de-escalation strategy compared with active control. The third trial was TICO trial. Dr. B.K. Kim and his colleagues compared 3 months DAPT followed by ticagrelor monotherapy versus a TICO-based 12-month DAPT in patients with ACS undergoing PCI. The primary endpoint was net clinical adverse event at 12 months, a composite of all-cause death, MI, stent thrombosis, stroke, and TVL plus TIMI major bleeding. At 12 months, the rate of primary outcome was significantly lower with ticagrelor monotherapy than with the ticagrelor-based 12-month DAPT, suggesting that ticagrelor monotherapy is one of the promising strategy in patients with ACS. Let's move to the patients with high and very high risk. The guideline recommend aspirin plus clopidogrel followed by aspirin monotherapy in patients with high risk, and they also recommend aspirin plus clopidogrel for 1 month followed by clopidogrel monotherapy in patients with very high bleeding risk. However, this guideline seems to be somewhat arbitrary, and there are very limited data supporting this recommendation. Recently, the results of a master DAPT study was presented and published in the New England Journal of Medicine simultaneously. The study was dedicated to patients with high bleeding risk. After 1 month DAPT, patients were randomly assigned either to abbreviated antiplatelet regimen or standard antiplatelet regimen. The primary endpoint was 11-month primary endpoints after randomization or 12 months after the index PCI, net adverse clinical endpoints. The study of this design is quite complex. Briefly, among patients without atrial fibrillation or other indication for oral anticoagulation, they compared 1 month DAPT versus 6 months or longer DAPT. Among patients requiring oral anticoagulation, they compared 1 month DAPT or 3 to 12 month DAPT. The primary, at 1 year, the rate of primary endpoint was 7.5% in the abbreviated therapy group and then 7.7% in the standard therapy group, which met predefined non-inferiority. Ischemic composite endpoint was not significantly different between the two groups, and the bleeding risk was significantly lower with the abbreviated therapy than with the standard therapy. This study demonstrates that 1 month DAPT is a promising strategy in patients with a high bleeding risk and ACS. In stratified analysis according to MI, the treatment effect of abbreviated therapy was consistent regardless of the presence of prior MI. However, in DAPT2 ACS trial, 1 month DAPT failed to demonstrate non-inferiority compared with 12 month DAPT. However, this study was not dedicated to patients with high bleeding risk, and they exclusively used the clopidogrel as a P2Y12 inhibitor. The last topic is choice of single antiplatelet therapy in stabilized ACS patients. The guideline recommend aspirin. However, there are several studies to compare clopidogrel versus aspirin in stabilized patients. Post-exam trial compared clopidogrel monotherapy versus aspirin monotherapy in patients who were event-free under DAPT for 6 to 18 months. The primary outcome was composite of all-cause death, MI, stroke, readmission due to ACS, and major bleeding. At 1 year, the rate of the primary outcome was 5.7% in the clopidogrel group and 7.7% in the aspirin group, which met superiority, which demonstrated superiority of clopidogrel over aspirin monotherapy. Interestingly, thrombotic composite outcome as well as bleeding composite outcome was better with the clopidogrel than with the aspirin. Now, our group are also conducting smart choice trial to compare clopidogrel versus aspirin in stabilized patients undergoing PCI. We focused on patients at high risk of recurrent ischemic events such as AMI, DM, or complex PCI. A total of 5,000 patients will be enrolled, and now 2,000 patients have been enrolled in this trial. In summary, in patients without excessive bleeding risk, 12-month DAPT are standard of care in patients with ACS. However, there are several options to prevent bleeding, such as shortening duration, switch to clopidogrel, and the reduced dose of a potent P2Y12 inhibitor, or early aspirin withdrawal. Thank you for your attention.